Mi nombre es Alan Contreras, soy cirujano de trasplantes y cirujano de hígado y agradezco al comité organizador la oportunidad de estar aquí. Tenemos un tema también ahora a discutir, así como están cambiando las cosas y estamos viendo mejores resultados con diferentes líneas de inmunoterapia o quimioterapia. También hay ciertos cambios que han pasado con respecto al tratamiento quirúrgico en hepatocarcinoma. Y para eso tenemos muchas clasificaciones, usamos frecuentemente la clasificación de Barcelona para ver qué tratamiento le damos a un paciente y ahora vemos que hay pacientes que no encajan en alguno de estos subtipos dentro de la clasificación y bueno, otra clasificación es la que usamos para ver si los pacientes pueden ir a trasplante o no, que es la clasificación de Milan. También es algo heterogénea, no es lo mismo un paciente con un tumor de 5.5 centímetros que alguien que tiene 3 tumores de 3 milímetros cada uno, o 3 centímetros, perdón. Y para esto quisiera invitar al doctor Peter Allen, quien es el director de cirugía oncológica en la Universidad de Duke, para que nos hable del tratamiento quirúrgico en pacientes que están fuera de Milán. Muchas gracias.
Buenos dias. Thank you for having us here. I recently moved from Memorial Sloan Kettering in New York down to Duke University in North Carolina, and we were fortunate to have several fellows in our surgical department in New York from Mexico and enjoyed the collaborations that we've set up with those surgeons here and certainly look forward to future collaborations as well. I'm going to talk about resection of HCC primarily in patients, as mentioned, beyond Milan criteria. And unlike Dr. Abu Alfa, who is constrained to prospective randomized data, as many of you know, as surgeons, we don't suffer from that because we don't have any. So I'm going to talk mostly about just the approach to these patients. So when we talk about surgical resection in patients with HCC, we're really talking about managing 2 different diseases. We're talking about management of the disease of the cancer itself, the stage of the cancer. We also need to be very careful about the function of the liver, because surgical resection in patients who have significant liver disease is associated with significant morbidity and even mortality, and therefore paying attention to both stage of the cancer and the stage of the liver disease is very important. As was mentioned, there are many ways of staging, or several ways of staging liver cancer. This is simply the AJCC system, and I put this up just as a way to look at the tumor itself, the T stage, not paying attention to nodal or distant metastatic disease at this point, but T stage and how that influences survival. And as we see, patients who have major vascular invasion or multifocal disease do quite poorly, with median survivals approaching those patients who have metastatic disease. So we argue a lot in surgical conference about who is resectable with HCC, and I think if we want to discuss what is considered classically resectable in HCC, it is those patients who have very little evidence of liver disease. They have a quality functional, a quality future liver remnant. They have a single tumor, no extrahepatic metastases, and they are technically resectable, meaning the tumor can be removed in its entirety safely. And this is the classical indication for resection. And if we look at survival rates following resection, we see that in the majority of patients who have limited disease, we see better outcomes than when we have patients that have more advanced disease. These studies all are a mix of patients, different size tumors, multifocal tumors, tumors with vascular invasion. And however, this paper right here, which came out of Memorial many years ago, I think is an interesting paper because it looked at resection within Milan. So not the outcome in all patients, but really only patients that were considered eligible for transplantation. These are essentially the Milan criteria: a single tumor less than 5 centimeters, or up to 3 tumors, all less than 3 centimeters. And if we look at the outcome in this group of patients, the 5-year overall survival was roughly 70%, felt to be equivalent roughly to, at that time, 5-year survival in patients who had undergone liver transplantation. So I think if we use classical indications, single tumor or 1 or 2 tumors, all very small, these are the survival outcomes that we can anticipate. So what about tumors that are beyond Milan criteria? And I'm really going to focus on 3 different subsets this morning. Those with a single tumor larger than 5 centimeters, those with multifocal disease, and then those patients who have major vascular invasion of the portal vein or the hepatic veins. With respect to solitary large tumors, I think the data around surgical resection is quite favorable in select patients. This is a study put forward by Tim Pollack, which was multi-institutional, looked at about 300 patients who underwent resection, and although their perioperative mortality was relatively high, what we did see in this study was that there is a group of patients with solitary large tumors who do quite well. The predictive factors or the factors associated with this have not been very well described, but in this paper, I think what we've learned is that those patients with very high AFP level, multiple tumors, major vascular invasion, or significant liver disease are those that don't do well. And that these patients who do well are those with a solitary large tumor, no major vascular invasion. Oftentimes, these are patients that have Hep B associated HCC, which can sometimes be found with much less severe liver disease. And so from those data, roughly a quarter of those patients presented without high-risk features. They did find long-term survival in roughly 25% of patients. And more importantly, in these patients with liver-only disease with a single large tumor, other liver-directed non-resectional therapies are less effective. As those of you who manage these patients know, these are difficult to treat effectively with other local regional therapies such as embolization, ablation in a 10-centimeter tumor. Very difficult to achieve effective treatment of that tumor. Multifocal HCC is a little bit more difficult to approach with surgical resection. There's a lot of argument when we see these patients in the clinic as to whether or not these are satellite lesions around a main tumor or whether it truly represents multifocal tumors in someone who has significant liver disease, or do these represent intrahepatic metastases. It's very difficult to sort this out. What has been shown, however, is that when we do resection in the setting of multifocal disease, there are very high recurrence rates, poor survival, and although some selected patients may do well, our only selection criteria right now seems to be the number of tumors. And if we're going to focus on patients beyond Milan, meaning greater than 3 tumors, those patients typically do quite poorly. And this is a study of 100 patients who underwent, quote, curative resection for multifocal HCC. You can see that the mortality risk was relatively low. However, those patients who were outside of Milan, meaning they had greater than 3 tumors, these patients did quite poorly and again had survival rates that were approaching those of patients with metastatic disease. These are the factors they pulled out of this study that were associated with outcome, and I think that probably patients who have greater than 3 nodules, we would very, very rarely approach those patients with surgical resection. Interestingly, though, however, this is one area where a prospective randomized trial has been performed, which looked at TACE versus resection in patients outside of Milan. And these results were interesting. We have had a difficulty incorporating these results into our practice because these patients, I think, were very, very highly selected. In this study of 180 patients, I think they screened well over 1,000 patients to identify these 180 patients. These were patients who had multifocal disease but had quite preserved liver function and were good surgical candidates. In this study, they did show, however, that TACE versus resection was in favor of resection of disease. How about resection in the setting of major vascular invasion? Again, a patient who's outside of Milan criteria. This is considered in the AJCC system stage 4 disease. I also believe in BCLC, this is stage C. These patients do quite poorly. Not only do these patients have advanced disease, but these operations are oftentimes technically challenging, particularly with hepatic venous invasion. They have significant mortality rates and significant morbidity rates. Near universal recurrence after resection, and very poor survival outcomes. These are data which looked at, again, from Tim Pollack, looking at resection in the setting of major portal vein resection, perioperative mortality rate around 6%, and again, median survival rates of those patients, similar to those patients with metastatic disease. Moderate to severe fibrosis, again, associated with very poor outcomes. These patients, highly selected, good liver function, but still with very poor both technical outcomes as well as disease-specific outcomes. So what is resectable? I think that the classic indications for resection hold. These are patients who have very good liver function, single tumors, and I would say probably single tumors, even those outside of Milan criteria, should be considered for resection as long as there's no evidence of major vascular resection. I think the data in those patients support resection as long as a negative margin can be achieved and as long as they have an adequate future liver remnant. I think in these patients, single lesions, preserved liver function, regardless of tumor size, we should consider surgical resection. In these other groups, multifocal disease, any tumor with major vascular resection, I think there should be significant caution as to whether surgical resection should be performed. It's rarely curative. There's significant morbidity and mortality, particularly in those patients who have significant intrinsic liver disease, and particularly in patients where we may have other effective local regional treatments such as TACE. These other treatments should be considered. I'm just going to spend a few minutes on a couple of the adjuncts that should be considered in managing these patients outside of Milan, and how we may employ strategies to improve resectability, both to improve the quality or size of the future liver remnant, to improve the technical resectability. Can we, quote, decrease or downstage these tumors and put them into a category where resection would be important? And could we utilize neoadjuvant systemic therapies as a way to improve our curability with respect to the disease biology? Portal vein resection is, portal vein embolization is something that is routinely used in patients where we are trying to increase the size of the future liver remnant. This is a well-established technique and has been looked at in prospective trials and shown to be beneficial, particularly for patients with intrinsic liver disease. This has been shown to decrease both postoperative complications and overall mortality with embolization of the side of the liver that we are planning to resect and subsequent hypertrophy of the future liver remnant. This is a well-established technique, and I think when we are looking at patients, particularly who have some level of intrinsic liver disease, something that should be really considered. There are technical approaches to resection that some may consider to be beneficial with respect to the technical resectability. I won't get into these in detail. These rely upon how we approach the liver in the operating room and how we resect the liver with respect to the amount of liver that is resected. There are some trials, an interesting randomized trial, which looked at simply approaching the liver slightly differently in the operating room with respect to how we mobilize the liver and how we divide the liver, showing significant improvement when we approached it anteriorly without liver mobilization. This study's not been replicated at our institution when we have explored this approach, but certainly something that could be considered. Another approach to improve resectability, and this is something that I think we really first took from the transplant surgeons with respect to providing downstaging of tumors, is can we embolize the tumor in a variety of ways to not only reduce the size of the tumor, pull it away from major vascular structures, but potentially also give us that biological test of time to see if these patients should be approached with an operation. Preoperative embolization is something that has been looked at and has been considered. If you have a tumor that is a tumor that you feel is technically difficult to approach because of its size or location, doing embolization can oftentimes result in reduction in size of that tumor and potentially allow us to perform a safe operation in the future. This has been looked at several centers. I think that this survival curve is very interesting because I think it splits almost immediately after these patients were placed on study, which suggests to me that not only does this embolization potentially downsize the tumor, but it also allows us with patient selection. That those patients who are going to progress outside of the liver or even progress within the liver are those who would not be taken to the operation, and therefore may allow us that test of time to identify those patients who have the disease that is appropriate for resection. I'm going to touch just a moment on systemic therapy. Dr. Abu Alfa talked about this in detail. Certainly systemic therapies have been shown to be effective in improving survival. Initially, we thought these therapies may also allow us to, quote, improve resectability, to, quote, downstage patients similar to embolization. We have not found that to be true in the majority of cases. The true response rates, meaning getting significant response, is certainly less than what we see in systemic therapies. And although these therapies are effective with respect to disease treatment and survival, we have not found them to be particularly effective in getting our patients to the operating room. So I would simply summarize that resectability for HCC is sometimes something that is much in the eye of the beholder, and oftentimes quite different if that eye is from a medical oncologist or a surgical oncologist. It has not been well defined. However, those patients with single lesions and preserved liver function, regardless of their size, should be considered for operative resection. Certainly, our technique has improved and has improved outcomes, but not necessarily expanded our indications for resection. I think the future liver remnant can be optimized with portal vein embolization, and we may consider liver-directed therapy in the form of intra-arterial therapies to shrink tumors may allow us to get patients to this endpoint. Thank you.